Okay, Dr. Salam, we able to see your screen. Please go ahead. We thank you,
Okay.
Dr. Salam, for starting.
Thank you very much for Iyama and the colleagues who provided this opportunity to talk to you. I'm really pleased for the first time to see you face to face. I'm Salam Hussein. I'm based in Perth, and I'm going to talk briefly about the overview of mood disorder and the treatment approach in depressive disorder. I have to say we have to acknowledge the traditional owner for any formal meeting, and I think Iyama is not an exemption to share these. And I would like people to mute themselves because I'm just hearing back noise, if you don't mind. What?
Can we mute all? I think.
Would you please? No, if you mute all, you mute me. But if you mute yourself, yeah, there's only one or two still going. There's some noise. Probably most of you know about these numbers, so I'm not going to present something really new. There's 1 in 10. I know that a couple of people will be working in private practice and hospital environment. That 1 in 10 patients with in primary care will present with depressive symptoms. So every 10 patients coming through your room, you think about the 10th one would be having probably depressive symptoms. Lifetime prevalence is around 7.5, and the 12-month prevalence around 4.1. And we know the female to male ratio in unipolar depression is 2:1. However, we know in bipolar, they are equal. The mean diagnosis onset of sort of diagnosis is around 27 years. In bipolar, much earlier, around the 20s, probably in the late teen. There's 80% of people with depression experience at least 2 episodes in their lifetime. Half of them can recover within 6 months, and 3/4 of them can recover within 1 year. However, there are 15, actually 12 to 15, that's the statistic, but there are other statistics in other places which showing probably up to 1/3 that don't recover and develop more unremitting chronic illness. This is a comparison slide between the prevalence we spoke about in Australia, which, as you see, the lifetime prevalence and 12 months prevalence, versus what 2 studies in Iraq in 2007 and 2015 by Al-Hamzawi and Al-Hasnawi. And surprisingly, the consistency in the 12 months prevalence across the 2 countries is is consistent, is really about that 4 point something. However, in the lifetime prevalence is much higher. And I think probably there's few explanation whether, the life expectancy in Iraq or the, reporting of depression all the adult may be really poorly reported. And probably that's one of the reasons why these data are different. But it's very interesting to see these differences in data. We cannot talk about the treatment. I know might talk about treatment without talking about phenomenology and diagnosis, and that's very essential component, how you generate your treatment without diagnosis. Probably all of you do the same things as we did with all medical diagnoses. We do demographics, we do comorbidities, and we do the illness itself, the clinical symptoms of the illness, and the illness history as well. And then we do details about the psychosocial domains of assessment. I'm interested in this one. As you see, this is a draft and very confidential. I could not share the slide. This is probably from our college guidelines now being under development. But really, I like it, and I felt really the urge to present it to you. Because this is providing a new aspect of how to look into depression and diagnosis. So the group collated all the DSM-5 criteria for major depressive disorder, for mood disorder in general, like bipolar and unipolar depression. And they divided it into 3 dimensions because they classified it, they already classified in 3 dimensions. As you see in the bottom of the screen, there's the activity dimension in green, there's the cognition dimension in blue, and the emotional dimension in red. And when you see, and the midline, if you see the midline, where if my pointer, does my pointer show on your screen? Yes, good. So this is the midline between the lower will be the depressive syndromes and the above the line is the manic syndrome, as you see from here. And the functional impairment as well along another dimension, as you see here, the more severe is up to the end of this direction of the slide. And in the depressive mode as well, the lowest part is the most severe. And when you see the symptoms, there are common symptoms in the middle, which is the irritable mood, this is the severity in the emotional dimension. If we go to the activity dimension in the depressive side, you see initially the fatigue or loss of energy, then it comes to the sleep disturbance, whether increase sleep or decrease sleep, and the weight or appetite, whether increase weight or appetite, whether in bipolar depression or decrease appetite, as you see. The activity domain as well in terms of severity. Remember, this line is representing severity. So if we go to activity to think or concentrate, indecisiveness, then it goes to more intense symptoms with suicidal ideation, plan or attempt, and the more severe with psychomotor retardation or agitation. Probably that's reached close to the catatonic state. If you think about this model, and the simplest way to think about the ACE model, and if I give you the acronym of ACE, that will be much easier for you to think when you assess patient. You ask them about their activity domain, their cognition domain, and their emotional domain to see whether you collated and cluster the symptoms enough to diagnose major depression or mania or a mixed state. In terms of diagnosis, as you see, we have the diagnosis, this picture as well from the current college guidelines. You could access it, so it's not me designing this one. But the mood disorder divided into the bipolar and depressive, as we said. The bipolar divided into 1 and 2, and the cyclothymic disorder, this all DSM-5 and ICD-11 as well. And the depressive disorder is the disruptive mood dysregulation disorder, persistent depressive disorder, major depressive disorder. You see, this is the domain of the primary illness. However, we have secondary mood disorders, which could be the premenstrual syndrome, dysphoric disorder, or the substance-induced disorder, mood disorder, or the medical mood disorder induced caused by a medical condition, like hypothyroidism, you know, other medical stroke, post-stroke, when you have secondary depression. So you see, there is this is very useful to think in the primary, secondary, etiological, because we consider the mood disorder, the primary mood disorder, as independent illness, as a disease state. As well, the secondary group would be a different sort of mode. Then people often, when they diagnose, they forget specifiers. And often I return really referral letters for ECT or for RTMS because the psychiatrist or the GP didn't sort of put the specifiers. And for the specifier to think simply, you could think about these colors. So illness pattern, severity, remission status, onset, clinical features. So if we go to each of these, we start with severity because it's simpler. There's a scale of severity from mild to severe. So you say major depressive disorder, severe, moderate. And that's very important and essential, even in remuneration, I think, in people in a private hand. Then the remission status, whether this in partial remission after a treatment, when you treat later, or in full remission. Then the illness pattern, is that single episode, that's the first episode, or this is a recurrent, or this is a rapid cycling, this patient being coming to you 3 times a year, and each time you diagnose them with a major depressive episode. Then the onset, how old are they? And that's very significant because if you capture somebody who is depressed in their 20s, you have to think bipolar depression. Even if they are depressed, you don't think unipolar because this is one of the features. So you have to put bipolarity there. And the treatment trajectory will be different for you and for the patient as well. So you could educate, you don't diagnose, this is not pathognomonic. That doesn't mean unipolar depression doesn't come in the 20s, but it's just to put in perspective. So you ask the patient about whether they have family history of bipolarity and whether you could pick bipolar diathesis. And then the clinical features of the major depressive disorder, whether anxious distress, mixed feature, melancholic features, atypical features, catatonic features, and psychotic features. Again, with the anxious distress, you have the severity scale, you put it there. And for the psychotic, you need to as well, if you really want to go deeper in diagnosis, you need to identify whether this is a mood congruent or mood incongruent psychotic symptoms. And I assume I'm happy to explain that, but I don't have time now to explain the difference between the simply mood congruent, the guilt, the worthlessness when reached delusional intensity, the mood incongruent when people in psychotic states similar to the schizophrenic delusion without related to the mood state. So the most difficult one, often even doctors in other specialties, they really struggling with the diagnosis of personality disorder. Is that personality disorder when they come with the traits of, with a lot of depressive symptoms, a lot of anxiety symptoms. And now the ICD-10 has shifted, as you saw from the ICD-11, sorry, will be shifting from that categorical diagnosis of personality disorder into what we call it dimensional diagnosis of personality disorder. So instead of say this is borderline personality disorder, you could this is borderline pattern. This is so I'll start from the top. This is negative affectivity. People who always negative about their emotion, about their feelings, probably that's what will be sort of dimensional diagnosis of personality. Detachment in terms of relatedness to others, disinhibition in terms of behaviors, dissociation, which is probably more with the personality, or that people tend to dissociate as a pattern of coping, and the obsessional personality, and as well the borderline personality. This actually way of describing personality patterns will help you when the patient come with depression, because often people, when they develop depression, their personality traits being amplified. So if they have like negative affectivity, you see very intense, more of this negative affectivity symptoms when they become depressed. And that's very important to address as well and to deal with it, because often people refuse treatment, negative about things, negative about recovery, negative about any initiative you provide in a treatment. And you ask, look, I'm being given them good options. They don't take it. Yes, because they have this pattern of personality, and these people often don't do well. I'm going now to treatment pathway because we talk about treatment pathway, and I want to a bit more concentrate on that. And this is another diagram from the current college guidelines. And I want you to focus on this sort of pattern, and even if you review it later on. As you see here, there is an arrow from reactive to psychotic mood disorder, whether it's depressive or manic. So the mania is here, but the psychotic is more severe. And there is colored sort of field, which is the biopsychosocial and lifestyle. And then there's the elliptical shapes with indicative of what the pattern of a treatment, or what's the type of a treatment that is most likely effective in particular type of mood disorder, at what scale of severity. So in simple way, as you see from the elliptical shape, the more severe, the more biological treatment is more effective and needed. The less severe, then probably other treatments will be more effective. As you see, in a reactive depression, you don't prescribe mood disorder, give them ECT because they've broken up with their relationship and they have difficulties in mood and they're dealing with bereavement. These could be addressed through lifestyle, through psychosocial approaches, as you see the elliptical shape here, for the less severe reactive illness. And you gradually assess and collate the severity of the symptoms and the type of intensity and impairment to actually decide what pattern of a treatment you're going to instigate for this person. And that's really essential. And if you see on a just start look, it will help the clinicians to design better treatment, even the GP in a very busy practice. And they got this 15 minutes to decide about treatment. A glance of this, oh, this person coming with psychotic depression, I do need to design like biological treatment and appropriate, whether refer or do something about it, because they do need admission. They may need ECT, they may need RTMS, and they may need both combination of antidepressant and antipsychotic. In the same way, as you see, the between mania and depression, the red is mania, the blue is depression, whether bipolar or unipolar depression, no difference. But the illness stages as well, inform your approach to treatment. So if the person see your treatment approach in the acute phase, you anticipate that's the term response, whether your patient response. And often if you are a GP, patient discharged from depressive, say, admitted to hospital, treated, they establish response, and they may come to you here. They're not completely in remission, but they responded enough to come to you to continue their treatment. And as you see, there's a fluctuation in the pattern in the time of remission to achieve remission. And when people are remitting, then you think when achieve this normality here, whether they came from mania or came from depression, then you think about the maintenance treatment, which is to prevent relapse. And they are in the recovery state, we call them. And these are really very useful, and many clinicians, even I'm a psychiatrist and I work in a treatment-resistant mood disorder, and this is my subspecialty. And still, it's very useful to think in this simplistic way to make things much easier and dividable. And look at your patient. Are they in the response phase? Are they in the remission phase? Or they are in the recovery phase that you want to improve their quality of life to prevent further relapse of depression. People ignore psychoeducation, and I do see many people. I receive a call from the hepatologist who work with the liver transplant, and he asked me about a patient with the steroid-induced mood disorder, which is actually about our talk. That's how I bring this example. He didn't realize I'm on leave, but anyway, he called and asked whether to start benzos or sertraline to treat this anxiety symptoms. And when I investigated with him what's actually the anxiety symptom, I found them, they affective steroid-induced affective symptoms for a patient with acute hepatitis who's been on a steroid. And then we designed the treatment as to go with a mood stabilizing. But I told him, no, the first thing, can you ask your patient about that? Can you educate your patient about that? And there's 4 dimensions now to educate, to approach psychoeducation. One, you invite your patient, make them partners with you. So, and the simple question, what do you understand by the term depression, or bipolar illness, or even psychosis, or even personality disorder? Just ask them this question. Will save you a lot of time not to dictate exactly what you're going to do. And then inform them about the available resources for further education beyond the blue. Black Dog Institute, CCI, they have really very good material. And trust me, I use it daily. I use it daily because I do consultation liaison psychiatry in the general hospital, and I refer patients and I print to patients information or sit with them, get the website on their mobile or their iPad and show them how to navigate through it. It saved me a lot of time. 5 minutes is done, and they read it on their own time. And when I see the next, I will explore with them what they did. So this is the third point of, so invite, inform, explore. And the other dimension is the new approach is the people with lived experience, because they do help self-help group. Is actually very useful and it's been finding itself at the moment with consumers movement and other things. It's really the lived experience seem to be valuable things to direct patients to, because they do feel acknowledged. They do feel that they are actually similar to other patients. Treatment-wise, choices. Remember the ICE in the diagnosis, there is the actions, there is the choices, and there's the alternatives. Here a bit difference. So if we see the actions, there are actions to do, and with the actions there are institute or address. What you institute to patients something new. You tell them about sleep hygiene. You educate them about sleep hygiene. You educate them about regular exercise. You educate them about diet. What you should address, medications that may alter mood, beta blockers. If you are a cardiologist, if you are, working in this, many medications that may introduce. If they are immunosuppressant, if you are an immunologist or oncologist, so you need to address these medications. Smoking is essential, and there's evidence that's connection with mood disorder. Alcohol and substance misuse need to be addressed as well. Then the implementation, what do you implement in the actions level? This is actions, this is not immediate sort of psychopharmacology or neurostimulation. So you implement psychoeducation, as we say, to the person, to their families, friends, if they are significant, and psychological approach, which is psychological therapy, like CBT, IPT, and various sort of psychotherapy module, as we mentioned later. Social support, people may need, because social isolation, especially in this era of COVID-19, and social isolation is essential. So not to address it is actually your treatment may not be effective. And then assessment of risk and assessment of outcomes, and keep monitoring. So book your patient if you are a GP. When you start a program for their treatment, book them again actively, not ask them or you come whenever you like. No, book them actively and keep exploring with them and monitor. Choices, yes, there are heaps of choices of antidepressant, many of you familiar with. We know the SSRIs, and you see the scale here is actually between efficacy and tolerability. And the efficacy more with the old class antidepressant like TCA, tricyclic, and Mayo inhibitors, and the amitriptyline as an example, versus the medication which is sitting in the middle with very optimum efficacy, but the side effect is better than the TCA or Mayo inhibitors, which is the SNRI, venlafaxine, mirtazapine, or bupropion. The SSRIs, which is example of escitalopram, it may be, and there's other serotonergic, which is a new vortioxetine, although it's not a BBS, and agomelatine, which is a melatonin-based receptors agonist, and it's as well is not on BBS, so you need really to discuss that cost for your patient. But the tolerability, so if patient doesn't tolerate any of these medications, then you may think about this sort of class of medication. In neuromodulation, people often ignore it, and I assure you, even these draft guidelines, and we are in a crisis about these mood guidelines with the college, because they didn't address neurostimulation very well. RTMS effective, probably closer effectiveness to antidepressant or even better for particular patients. So if a patient didn't respond to antidepressant trial, you may consider RTMS, which is the transcranial magnetic stimulation. ECT, still if the patients before that they had ECT, why you don't refer them for ECT if found to be effective, why you get them into the same channel of suffering for weeks if really they already only responded in the past for ECT, or they may elect. And I just had a referral a few days ago that they are sort of a patient who be referred for RTMS, and they elected ECT because they read and they got information more about the efficacy and they want efficacy. Surely you have to explain side effect profile of these treatments, and there's a lot of literature, a lot of information, patient information available. Obviously, they are done in a specialist center. So if you are a GP, you need to refer to these specialist centers. Direct current stimulation, it's find itself is still the evidence is building up. But for patients who don't respond and you need a non-convulsive therapy, probably TDCS would be an option. And the alternative, whether you switch, you increase the dose if your patient didn't respond, increase the dose, or augment with another class, or you actually switch to another class and then augment. So whatever your alternative, you think about it. I would say if your patient did a response with your first choice, you may need really to go further for referral. That's probably repeating the other slide, and I won't take more time. And this is about the psychotherapies we mentioned. There's a list, and I could send these slides, which I can't send to Dr. Mohannad and to distribute to the group. And the new therapy is based on circadian rhythm. You need to be aware about it and ask patients, especially shift workers and people who travel a lot. And the light therapy as well, been finding itself now in the new treatment paradigms, because they are even effective in a climate like Perth and like Australia, not only in Scandinavian countries, because seem to be this particular therapy is especially for seasonal. Children and adolescents, there is a tier for treatments, and you need to consider specific referrals for them. And yes, if your patient didn't respond to treatment and you're stuck with them, and you find yourself really in dire situation, because either the patient in green, they respond, or the patient in a blue, they partial response, or people in red, they don't respond within a few weeks of a treatment, then you need to consider other options. I won't talk about the data because I think I'm running out of time. But what I want you to think is really about this diagram, which is I will send to you as well. You think about the blue dimensions with your clinical management to review, and as well the orange, which is therapeutic strategies you have to consider. And these are very essential for you. ECT, we spoke about it, and ECT is really effective and should be the first line treatment for patients who's severe, who's high risk of suicide. Don't hesitate to educate your patient about it and refer to specialist center. And RTMS as well could be considered, even for people who do respond to ECT. And apology if I took 20 minutes. Okay, it's supposed to be 15 minutes.
Thank you very much, Dr. Salam. Very informative presentation and very illustrative. I enjoyed it. Perhaps if everyone agrees, maybe we postpone the questions to the end of the presentations, and then hopefully we can have a closing 15 minutes for discussion. Dr. Mudaffar, you next have received your presentation. Are you still not able to share your own screen, or I can put your presentation on if you like? Can you unmute? Can you unmute? Can you unmute? Dr. Mudaffar, if you can unmute, please.
I think you can unmute him yourself, Dr. Mohannad.
That's tamam. Yes, all good. I try to send my request.
What
okay.
about now?
That is okay. So just a second ago, I was able to see your presentation, which is Right.
Is Dr. Muzaffar sharing or?
Yes.
Muzaffar, how you share?
Can you hear me now?
Yeah, I can.
Now we start. Now, Doctor. Yes, we start.
Yep, great.
I cannot. Can you enlarge your screen?
I am trying. Please forgive me.
Just go to this one.
All good. All good. I can see you.
Excellent.
Yeah.
Just put this one. Yeah.
Yes.
Perfect.
Thank you very much, and apologies. I'm still learning. Look, we'll talk about somatoform disorder. It is just that kind of group of disorders that there is physical symptoms. The patient is complaining about symptoms. And regardless if you are a GP, a physician, a surgeon, they will come your way one way or another. And it is a very common problem, especially affecting our cultural group as Iraqis, Easterners. We tend to have that sort of complaints. And I'm sure every one of us who worked in Iraq, we may have seen a conversion disorder many times, or you treat a patient and they keep coming to you with the same complaint. So that is part of the group called somatoform disorder. It is basically 5 conditions: somatization disorder, conversion disorder, hypochondriasis, body dysmorphic disorder, and pain disorder. I elected to speak about the first 3 and maybe mention a thing or two about the body morphic disorder. The pain disorder by itself is a very important topic, but it will need more time to explain it or talk about it properly and adequately. Somatization disorders affect 2% of women overrepresented than men, perhaps due to less diagnosis of somatization in men. Usually starts before the age of 30. We often see a middle-aged man or a woman complaining of certain group of symptoms for years, and I have seen this doctor, I've seen that doctor, nobody knows, and they are not really good doctors, and that is the usual story. And if we look deeply into the quality or the type of personalities these patients presenting with, they usually are neurotic by nature, and they fall in the group of either avoidant, paranoid, or self-defeating and obsessive compulsive disorder. The etiology why this is happening, nobody knows, but there is some research showing there is the cytokines and interleukins in the brain are responsible for causation of such condition. The diagnosis usually it is like too many symptoms. There are 4 types of pain, different pain: headache, abdominal pain, back pain, chest, rectum, menstruation, sexual intercourse, and urination. This is purely pain symptoms. And there are also 2 other symptoms: GIT, other than pain, nausea, vomiting, and there is 1 sexual or reproductive urinary system problem other than pain. And there is associated also pseudoneurological, like impaired balance or paresthesia or paralysis. Often patient comes to you, the clinic and say, "Idi khadrana," it has been there for many, many years. That's part of this group of symptoms. The interesting part that all the investigations, all the physical examinations are normal. And the problem is how to reassure the patient. They come to you over and over and over with the same problem, and all your tests show normal results. However, I have to mention some statistics showed the so-called somatization. Some of them really suffered serious medical illness that was not diagnosed. And this does happen, unfortunately. So there have been like, I know someone who's been diagnosed with irritable bowel syndrome for many, many years and turned out to be not.
That's very correct. Correct.
The treatment, basically a few things we can do. First, there has to be one doctor only responsible for the coordination. The problem is doctor shopping. This doctor may to him, I will go to another one, and this creates a problem in the treatment. So if you can convince them to stay with you as a family doctor, that would be great. And the trick is to book them for, say, 6-7 months, monthly visit. Not, I don't leave it to the patient. No, it has to be booked regularly. What does that provide? Each time the patient comes, will be examined, will be listened to, will be discussed with, so the patient feel that they are supported and they are not ignored, they are not abandoned. That is the core simple step in the management of such neurotic patient. Of course, this happens only after exclusion of organic disorders. From that moment onwards, any investigation should be discouraged unless there is objective reason for it to be ordered. The other mainstay of the treatment is therapy. Unfortunately, people of our cultural background, once you say to them therapy, they will say, "Ani mu mkhabbal." Then how are you going to convince them? But the reality is, we tell them that the therapy is to address the stress caused by these conditions. So I don't collide with the patient saying, this is only in your head. I do not say, yes, this is 100% is organic. I will say, look, you are under a lot of distress, and I believe that therapy will assist and help in modifying your response to such conditions. In the West, as you know, there is always calculation of cost. This, the somatization disorder cost is huge in terms of admission, in terms of investigation, in terms of loss of worked hours, and therapies appear to reduce that by 50%. Referral to a psychiatrist will be also an important step if the patient agrees, because as Dr. Salam mentioned earlier, when there is depression, there are other traits appear in the body, in the behavior. There are other comorbidities, mainly depression and comorbid anxiety, then that if it treated can produce much reduction in the symptoms. The conversion disorder is a common problem. We've seen it in emergency departments. It is different from malingering, as we all know. What it is, like, there are 3 terms introduced early in the century, which is conversion, changing of emotional distress to a physical distress. The other concept is sickness behavior, and the third one is sick role. Each one by itself will shape how the patient present and why they present. Conversion comprises of 5 to 15% of psychiatrist consultations in general hospital, and male to female is 1 to 2. And it is caused by repression of unconscious conflict and conversion of anxiety into physical symptoms, especially in like Eastern cultures, where they believe that physical illness is more acceptable, mental illness is weakness. the treatment is more or less similar to somatization, but the main thing is the family support. You don't tell them off, you don't pressure them, you don't say, get out of it. Anxiolytic and antidepressant is helpful, but the main step is whatever stress troubling that person need to be dealt with. Otherwise, there will be no resolution. I don't know if there is enough time to go other hypochondriasis and treatment. I will save a few time left to Dr. Wael to present. And my apologies for hurrying up.
Dr. Mohammed, you're mute. I can't hear you.
Yes.
That is all right. Now, how about that?
Yeah, good. Now we're good.
I thank Dr. Mudaffar for the presentation. It was nice, summarized, and to the point. I'm sure we have more than one question, but how about we group them to the end? And the more we group them, the more they become. Next is Dr. Wael Duri. I don't need to introduce Dr. Wael. Everyone know him. He's a very senior person. Very glad to have you with us, Dr. Wael. Please go ahead. Can I see your presentation? Can you share your screen?
Well, I thought I'd start sharing, but I sent you the presentation. I click on share, but I'm not sure if it's happening or not.
Dr. Mudaffar, you need to unshare yourself. So
Yeah,
just please, if you unshare and Dr. Wael, because
thanks, Dr. Mohammed. Much appreciate for this opportunity. Thank you, Dr. Ahmed. So I'll just spend a few minutes talking about the OCD. Probably this more is a direction to our kind and GP colleagues. When you think the OCD clients need a treatment, and what's the difference between OCD personality or OCD behavior or a perfectionist or OCD disorder? It is when the OCD symptoms, whether it's obsession or compulsion, affect the quality of life, interfere with functioning and performance. At that time, probably you need to, advise your client to see someone. So I won't go to details of the DSM-5 and the obsessive compulsive, and now because they are different categories, and now because we have only if you have only obsession, they call it pure OCD or pure obsessional. That's more of statistics. So I'm just refreshing our mind about what's called by obsession, which is a recurrent, persistent thoughts, with thoughts or impulse or images, or are very intrusive and cause a lot of anxiety and distress. Person trying to ignore it or suppress it, neutralize it as much as they can, and they cannot do that. And most of the clients, they are aware of their obsessional thoughts and impulsive, and we call ego dystonic, and they know that it is their own thoughts or impulse. And in fact, that's the hallmark we differentiate between obsession and psychosis. Well, within the compulsion is just repeated behavior to neutralize the obsession, and the behavior mental act are usually directed or preventing reducing the stress. These behavior mental acts may be always associated with content obsession themes, such as contamination and followed by frequent washing and cleaning. Some symptoms of OCD are part of the other psychiatric disorder, which substance abuse, or even can be you find OCD even psychosis and mania. The subtypes of OCD, the contamination obsession with washing and cleaning, probably that's more severe nowadays. We're seeing with COVID-19 advice, and imagine you are OCD with cleaning, and someone tell you how to clean with the soap for 20 seconds, So we are feeding his OCD, poor guys. If you have this symptom subtype, you usually focus on feeling discomfort associated with contamination. So you go and wash your hands, repeatedly. So you may feel that your hands dirty or contaminated after touching everything. You worry about contamination. COVID-19 nowadays, get rid of this feeling, you start washing your hands repeatedly, and you may even damage your hand skins. Harm obsession is checking compulsion. they experience this symptom subtype, often you have intense thoughts related to possible harm to yourself, others, usually a family. So you used to check rituals to relieve your distress. So an example, you imagine your house is burning down and they repeatedly drive by your house to make sure there's no fire. So you leave your home, lock the door, go outside, you have this obsessive thoughts that your house will be burned, you return back, keep checking everything, and let's go on. So an example of this, someone who had put a list to check oven, check locker, wash hands, blah, 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 clean toilet, repeat, then repeat, and continue. That's more of an example of obsessive. Obsession without visible compulsion. So this is a subtype of unwanted obsession. Most of these are thoughts, which is very painful for our clients. Sexual, religious, aggressive, a lot of these things, which is a bit hard for the clients to the patient to tolerate. One of the obsession thoughts, usually I give this picture or photo to my clients when I have OCD and ask them, do you have any of these? And one of the clients was just burst in tears. When he went through all these, he said, I have all of them. I always feel that I'm gay or a pedophilic or a bad boy, things like that. So these are most of the obsessive thoughts, which most of them are either religious or sexual or painful. Symmetrical obsession with ordering, arranging, counting, compulsion. These are all different types. Probably I won't spend time there. Hoarding now is a category in DSM-5. Hoarding is a behavior. We keep hoarding things. I know one of my colleagues. He's a kind GP who's been hoarding medical journal for 20 years. His garage is full of medical journals until his wife, he's talking either go home or take the medical journal out. It's a poor guy. He took the peaceful one. This is the hoarding, especially now with the COVID-19. Imagine what this girl is hoarding, which we saw on TV, and this poor husband is out of home. That's a nice one. Some of the definition of this system, probably that's too much, I'll go for it. There's some of the disorders are linked now to OCD. There's skin picking, hair pulling, body dysmorphic phobia, things like that. And there's a lot of etiology of causes about that. Probably I won't go there for that. Risk as probably of obsession is obvious for everybody. Family, stressful life events, emotional distress, other mental illness, depression, anxiety, tics. So there's a lot of that. Why OCD is difficult? Because there's complication. Time consuming, ritualistic behavior, health difficulty, trouble, suicidal thoughts, behavior, depression. There's a lot. I won't go in details for depression because usually it is treatment, SSRIs, SNRIs, according to FDA approval. We have about 5 of them. Last one is anofranil, the famous one, which is used in old age for 90s. This is the graph of how we assess the severity of OCD and what we do one by one and what's the end we can do. So probably that one, the end, if the OCD is not responding to a simple SSRIs or SNRIs, this probably is the time to send your clients to a specialist. This is more of augmentation therapy. We use it, which we add something else other than antidepressant, lithium, stimulant, antipsychotic. A lot of trials here and there. That's a promising. The TMS now using for depression. OCD is probably there's a future for TMS in OCD, deep brain stimulation for OCD. So new things about antibody, using this, and probably just more on the research. And imantidine glutamine, we've been using it here and there sometimes. I haven't used it honestly, but we use it for dementia, and they said this have a good effect on OCD if it is augmented with SSRIs, SNI. Thank you. I try to make it short.
Thank you very much, Dr. Wael. Once again, very nice presentation. I'm sure there is some questions I can see. الأساتذة يعني جاوبوا بعض الأسئلة. شكرا جزيلا. We perhaps open the panel for questions, and I might start as a one question to Dr. Muzaffar. Dr. Muzaffar, I understand the somatization sometimes is a headache to us being on call as surgeons, and it can be different ways. And unfortunately, we have to deal with it, as you mentioned, from A to Z to make sure there is no physical origin to it. And I remember one interesting case that the GP was dealing with that patient with abdominal pain and labeled as somatization disorder and treating her for 1 year. Then she went into real crying and depression and referred her to a psychiatrist who examined her in hospital and found an abdominal mass, performed the CT scan, and rang me saying that that is a liver mass for you. And I was very impressed by the skills of the psychiatrists. I think this is extraordinary. And the question to you, Dr. Mudaffar, so those people I see.
Huh? Yes. Yes. The light. Yes. Okay.
Those people I see in hospital, they get lost in the system again, because we tell them, for example, there is no surgical or any disease from the gastroenterology to diagnose, and then we send that in a discharge summary to the GP. And I don't think our system supports robust referral of those cases, especially if they have repeated presentations, to see a psychiatrist, as you mentioned, to work a specialized plan for them and tailor a treatment. What's your comment on that?
This is a real problem, and some study found in the best centers in the world, sometimes up to 75%, they go that high, they have a structural or organic problem that is or was undiagnosed, unfortunately. But this is not a very reliable study. What I'm trying to say is, if the basic investigation are done and the symptoms does not fit the clear signs and symptoms of a given disorder or an illness, I think it is safe to assume, especially if there are 4 types of pains, different pains, 4 types of systems involved, then that will fulfill the criteria of somatization. But one important part of it, if the symptoms appear before age of 30, that's a very important aspect. Why before age of 30? It means the personality, it is congruent with the neurotic type of person, that is highly likely they have a somatization. So it's like the full criteria of 4 different pains, 4 different systems, start before age of 30. But if the person comes with a specific system symptom, I don't think they will fulfill the criteria of somatization. But they fall under either chronic pain syndrome or body dysmorphic syndrome, and that's a totally different matter.
Thank you very much. Dr. Salam, do you like to add a comment? You raise your hands.
Just one comment on, I know it's really struggling, and historically, as Dr. Mudaffar said, it's been really struggled to deal. I'm doing consultation liaison as well, 0.5, and that's the bread and butter of daily work, and I work with the chronic pain. I think if you look into DSM-5, there is shifting in thinking how we deal with somatoform disorder, as we call it. Dr. Mudaffar presented very well, solid presentation about DSM-4. The shifting in thinking is really we consider as the functional element of the disorder. In the past, we think either organic or non-organic. Now we moved away from this binary thinking into that, like if I use the analogy of computer, we got software problem, we got hardware problem. So that will enhance the continuous work. I think a liver mass should not be missed. And the things that, in a sense of discourage to discover that. And it often happens with, say, functional neurological disorder, with chronic pain disorder, with, as they call it, because we don't call now conversion disorder anymore, because of that exact element. To remove this binary thinking, either psychological or organic. We have to think in that continuum, so at least we don't miss the cases that could be, having some structural changes, as Dr. Mudaffar said.
Thank you very much, Dr. Salam. There's a couple of questions. So one of the question is from the audience: can CBT used as a treatment for OCD? Dr. Wael, could you comment on that, please?
Hi. Yeah, that's a good question, man. Part of the whole holistic treatment of OCD is medicine and, of course, behavioral therapy, and one of them is CBT. By the way, it's generally it's definitely help, but yeah, we need to assess the severity of our OCD and whether it is only the symptoms or only disorder the clients have before we go ahead with the CBT. So my advice, we need to assess first the severity of OCD, how much is interfering with life, is the client is fit to get medical treatment, is it mild, moderate, or severe, and then most of the time behavioral therapy, CBT can be useful for OCD, because most of the OCD guys will present with anxiety, comorbid anxiety and depression. So either way, which is efficient for OCD or the comorbid anxiety and depression, can be very useful.
Okay, thank you. And there's another question to you, Pat, Dr. Wael. Can you quickly summarize the diagnostic pathway criteria for OCD as a take-home message?
Well, just in general, recurrent, persistent thoughts, impulse, image, which cause a lot of distress in the clients when he try to block it or stop it or resistant. And the client must know that it is on own thoughts, impulse, and thoughts. It's not an this is not from outside, coming from outside. And to fulfill criteria of OCD disorder, it had impaired his performance and function in life. If there is no impairment, there is no performance problem, or he's not disabled, this is not an OCD. This is probably a personality or perfectionist. That which make a difference between a disorder, personality, or symptoms. And I presume probably all of us have some obsession here and there, and all the doctors have some obsession. That's why they're successful in their job. But when the obsession interferes with your life, like you keep cleaning your hands 24/7, or you keep checking the windows or the cooker or things like that, or you have rituals which affect your performance, then you need a treatment.
Thank you very much. I think next, Dr. Ahmed Rubai, you have a question. Proceed, sir.
Yes. First, Dr. Mona, let me thank with great appreciation the time and efforts and the excellent presentation, and very precise actually, for our colleagues Salam and Mudaffar and Dr. Wael. Sorry, I have in fact 3 questions, but I'll put them together. The first question regarding irritable bowel syndrome. Now, the emphasis in the managing irritable bowel syndrome, moving toward the concept of brain-gut axis. And there's a lot of therapeutic modality regarding the irritable bowel syndrome, which used to be thought as a functional disorder, but now we are moving toward a more organic background for that. My question is, what's the intervention our psychiatrists can put into the management of irritable bowel syndrome through this axis, as this IBS is not somatization, is not just a functional disorder. This question is directed to our 3 colleagues, Dr. Wael, Dr. Mudaffar, and Dr. Salam.
Can I start on comment? Because, I had a colonoscopy last year, and the gastroenterologist told me you need to avoid stress in your life. So, I told him I'm a psychiatrist, the stress is my life. So, yeah, so when we laughed, I laughed. I mean, we had a long discussion with him about that. And I totally agree with you, Dr. Ahmed. Irritable bowel syndrome is part of an anxiety, depression, and even you can find it in schizophrenia. And, the way we explain to the clients that your intestine, your stomach, your GIT system is anxious like you, restless like you. When you're in anxiety, depression, or even psychosis, schizophrenia, get well and relax, your intestine or your GIT or motility get well. Definitely, almost all of us tried medicine here and there. Some of the SSRIs, SNRs, even some of us trying the tricyclic or tetracyclic to help with that. What I'm trying to say, it is probably a combined, from psychiatry and the gastroenterologist to help the clients to relax, control the anxiety, as long as keep their intestine and motility functioning.
If I may add something.
Go ahead, please.
There is this long, old schism problem between mind and body. What is mind and illnesses, and what is body and illnesses? And one of the thinkers in this field gave an example of pain. Pain, it is definitely a psychological feeling. It is not something you can quantify or you can explain, but pain also can cause myocardial infarction. So what we describe as a bodily function, it is actually intertwined, and you can never separate it from the emotional state. When I was working in Sydney after hospital work, I saw a lady with cardiac neurosis. That term was mentioned in one of the cardiology lectures in year 6, and I remembered the cardiac neurosis. It was very interesting to me. How can the heart be neurotic? Basically, her heart rate was above 160. All the tests is done. All kind of intervention is done. No abnormality. And so I gave her fluvoxamine. The lady was so sleepy from a very low dose of fluvoxamine. She went back to her general practitioner, who would kindly reduce the dose further. But the happy news, her pulse rate recovered back to normal rhythm. And I could not explain that, but this is an example of how the body functions depending on the stress or lack of it.
And just to comment, another comment on different line as well to you, Dr. Ahmed. Even if we discover that the immune system has relevance to the irritable bowel syndrome, if we, the gut sort of lining and the gut-brain sort of reflex, but this doesn't mean that this is not interconnected, because we know mood affects immune system. We know the immune system, there's hypothesis that actually mood disorder has some relevance in the immune system. So still, I really encourage our colleagues, surgeon and gastroenterologists, to talk in that holistic, comprehensive way, to combine that, even if they got irritable bowel syndrome. Yes, probably you do need help. You need to help me to treat this irritable bowel syndrome by attending to these, because I identified this. If you do screening, say with some citrus or self or healthy questionnaire in your clinic, and you find this person at high citrus level, then probably, as Dr. Weil and Dr. Muzaffar rightly sort of commented, you would need to sort of include psychological or psychiatric treatment as part of your approach. And that will be very helpful. We work closely in consultation liaison with our colleague in gastroenterology. I don't think we could work now in this binary thinking. Is not helpful. And even if you are the surgeon who come to your patient and say, nothing wrong with you, the patient would say differently, because they do feel differently. They have pain, as Dr. Muzaffar say, pain is a subjective experience. And to be a subjective experience, you cannot, whether you cut your hand or you have functional pain, is the same pain. And there is no difference between the quality of this pain, between cutting the hand and as well the functional element of that pain.
Can I have one last question, Dr. Mohammed?
Go ahead, please.
Yeah, this probably directed to Dr. Muzaffar with the somatization. Where you put Munchausen syndrome in this prospect? Is it part of somatization or not?
Munchausen?
Yeah.
Munchausen syndrome does not fall into that category. yes, it is a psychological illness, but it comes with one single complaint. Unless, sorry, I need to step back one little step. I mentioned the three concepts: the conversion, sick role, and illness behavior. Those three concepts explain why people present with illness that could be categorized as mental illness. If there is a primary gain, or if there is a secondary gain. A primary gain in terms of the care the system provides, whether it is a doctor, nurse, kitchen lady, anyone in that environment, all that care delivered to the patient, that is regarded as a primary gain. The secondary gain, as we know, when there is either monetary value, benefits, or somebody escapes from duties or having time off, this is the secondary. So it depends what the patient is getting out of it, because the patient do not do things without a reason. It could be subconscious, but still it is a big motive for the person to present with paralysis of the right arm. And that explained by the sick role or illness behavior can be very clearly explaining. But back to your question, Munchausen syndrome is to basically there is a pure primary gain. There is a psychological need for somebody to care for me, and that is a subconscious need. Thank you.
Thank you very much. I have a one last question, and actually I prepared that question for the last month. I've been waiting, and I am honored tonight by all of your expert presence. The question belongs to all of us, the clinicians. We know that in our first day of practice, we seek work, and then very soon after, we cannot cope with the amount of load that the work is coming to us. I work, for example, 5 days a week compact, and the hospital is negotiating with me operating on Saturday to deal with waitlist reduction against my will. The question to your side, to all of our psychiatrists, what is the expert advice you would give all of us to protect us from the burnt out state? We all vulnerable and exposed to this as a risk, being very busy clinicians. We even receive consults via text message at 10 p.m. from colleagues asking us to see a patient next morning. What is your advice to me with that regard?
Dr. Madhav, do you want to go, or shall I go with this one?
I think we divide it amongst ourselves. You go first. Because one of us may have some.
Yeah, I think Dr. Mohannad, and to us all, I think we are in the same sort of category. And as Dr. Wal said, psychiatrists are not less stressed than other specialties, and that's what they found is really high stressful. However, surgeons surely at the high stake. And the best ways to deal with that is what we call it as a professional body, probably your College of Surgeons or, College of Medicine and GP have some, mentorship programs and have talked about boundary setting. And that's very important. Is really with your organization. The organization is, I often call them psychopathic organization, because they do absorb you without you knowing. And you do need to be aware about that, whether you are in the private because of the incentive to work harder and harder and harder and escalate, and in the public because you push to work harder and harder because of waiting lists and you're conscientious. And that's what important. Dr. Weil identified us, all of us, as having element of obsessionality. That's why we are in this profession. And we need to be careful how much this obsessionality and perfectionism and consciousness not to be drawn into a burnout, to be watchful of your lifestyle, to be watchful of your sleep pattern and all these things. And this is very essential. Sorry, Dr. Ayad. Yeah, Dr. Ayad, there's noise. Can you mute yourself, please? Thanks. Yeah. So I will leave Dr. Mudaffar to further comment, but that's the main thing is really setting the boundaries, looking into your lifestyle, and as well looking to signs, early signs of burnout. When you start the irritable mood, when you start not sleeping, when you start using more caffeine, when you start probably, if you drink alcohol, you start drinking more alcohol to cool down after this terrible days of, say, back-to-back surgeries and list and round and on calls.
Thank you, Dr. Salam. I might add a simple few things. I think we need to look inwards about whatever we're doing, why we're doing it. Initially, all of us, we needed to have financial recovery. Once that is achieved, the financial security, we are under this pressure of getting professional satisfaction because we are trying to solve problems. We are trying to heal people. We are trying to solve everything comes across us. But the reality, after a while, it becomes more like a conveyor belt sort of thing. Then, if you look at it, the type of medicine we practice in Iraq, type of medicine we are practicing now, the whole concept is changed. It is not purely medicine now. It is more transaction rather than a true medicine that the patient comes to you. If you don't intervene, they die, that sort of thing. What I suggest from my humble experience is to build an interest. It is never late to build an interest. You have to look deep in yourself. I need to have an interest. That interest, I would give it either a Saturday full day for yourself. I know the weekend it would be for the family, but also you need to find time for yourself. I personally dropped to 0.6, 3 days a week. I'm not a millionaire, alhamdulillah, but I think I need to stop and say why I am running that hard. If that can answer anything or can help to share with you, and thank you for this wonderful question.
Thank you very, very much. Actually, it was a wonderful evening. I was privileged by the 3 experts in the field from 3 different states. I think that is an achievement. A big thank to all of our experienced presenters, and even a bigger thank to our senior colleague, Dr. Ahmed Al-Rubai, as a father of all of this. And I really enjoyed this evening. Many thanks as well to the audience. And if there is any more questions, we're very happy to have it. Dr. Wael, do you want to say any comment?
No, thank you so much, Dr. Mohammed, and thank you for this opportunity. Thank you, Dr. Ahmed, for that. But, you know, Dr. Mohammed, my advice to you, watch when the border will open and go for overseas.
You could have fun. You could have fun within your state as well. Just enjoy the time being.
Absolutely. Once again, I thank everyone for the wonderful evening. And Dr. Ahmed, do you have any comment?
No, it's not a comment. Thanks all again. Thanks to you for all this hard working actually in managing this, both preparing and moderating. I have just a question of survey for our colleagues. Is a weekday better for them than a weekend for these webinars? Because we are in the process of having this as a monthly session covering different specialties and different topics. And we are having now an establishment of a YouTube channel related to the AYAMA, where all these recorded webinars will be stored there and then accessed by a wider community there. So from your perspective, is a weekday better like today, or a weekend like a Sunday between 8 and 9, or we need to do some survey about it.
I think we are only here at 12 people now, so we cannot probably give you a valid survey.
No, but
I think I would suggest that survey to be sent within the group.
We will.
And within and to see really, because we are different specialties, and now there's 13, 14 people attending this webinar, which is very reasonable. People who want to cross specialty to learn, and within a specialty, there will be variable interest. And I think to generate a survey within the whole group, but surely for me, there's a 3 hours difference with you. And it depends on what the timing of, luckily this time I was on leave. So I am happy to attend.
Well, Dr. Ahmed, you know, when it comes to the weekend activities, we need permission from our wives. It's a bit hard, you know that.
You just said we need a one day, all day for us, Saturday.
Come on. Come on, Dr. Ahmed, you know how the situation.
The wife is first.
Okay, yeah, but that's what I'm trying to say.
انتبهوا هاي بالآخرة ترى وراكم النسبة.
أكيد.